You're listening to the lecture on assessment and management of patients with biliary disorders. The objectives for this lecture are for you to be able to describe the pathophysiology, clinical manifestations, and medical management of cholelithiasis. Use the nursing process as a framework for caring for a patient with cholelithiasis and those undergoing laparoscopic or open cholecystectomy. Differentiate between acute and chronic pancreatitis, and explain the nutritional and metabolic effects of surgical treatment of tumors of the pancreas. So make sure that you review the A and P. Disorders of the biliary tract and the pancreas are very common. They include gallstones, gallbladder stones. Pancreatic dysfunction is also common. So make sure you understand the A and P. It will be a lot easier if you understand A and P of the gallbladder, pancreas, and then tie that into the liver as well because they're all there together. Enterohepatic circulation is a pathway of the bile salts from the hepatocytes in the liver to the bile, to the intestine, and then they go back into the hepatocytes. So the bile salts actually get reused by the body. Gerontological considerations: increased fibrous material in the pancreas as well as localized arteriosclerotic changes can affect the ability of the pancreas to function. Decreased rate of the pancreatic enzyme secretion and decreased bicarbonate output occur as we age, and calcium absorption as well as fat absorption can also decrease. Cholelithiasis is a gallstone or a stone in the gallbladder, and cholelithiasis is a stone that's more in the common bile duct than in the gallbladder itself. The stones can be pigment-based or they can be cholesterol-based. Most of the time they're cholesterol-based. Obstruction of bile flow will interfere with absorption of fat-soluble vitamins. Vitamin deficiency can be seen with prolonged obstruction. Cholelithiasis can be acute, it can be chronic, and it can cause cholecystitis, which is inflammation of the gallbladder. The inflammation of the gallbladder will cause pain, tenderness, and rigidity of the right upper quadrant of the abdomen. This pain can radiate to the midsternal area or the right shoulder, and it can be accompanied by nausea and vomiting. Calculus cholecystitis is the main cause of acute cases of cholecystitis. Ultrasound is generally done as the diagnostic procedure of choice because it's accurate, rapid, and generally lower cost than doing a CT. If a patient is getting an ultrasound, they should have fasted overnight if possible. And here's pictures of different gallstones. As far as medical management and ERCP, which is an endoscopic retrograde cholangiopancreatography, allows for direct visualization of the hepatobiliary system using a fiber optic endoscope. And so it actually you go in through the esophagus, which is the endoscopic part, and then they can actually go into the gallbladder and feed down and see the pancreas as well. ERCPs do require informed consent. Moderate sedation is used for an ERCP. You want to monitor for central nervous system depression, CNS depression. Make sure they don't have oversedation. Make sure they're not vomiting because they can aspirate because of the CNS depression. Watch for respiratory depression and hypotension as well. An ERCP, if done to go and remove gallstones, can cause pancreatitis, but it can also be used to diagnose pancreatitis and get biopsies. There are non-surgical ways to remove the gallstones, and that's with the endoscope. Like I said, the ERCP can go and pull it out. You can also have laparoscopic or open cholecystectomy. Bile duct injury is the most serious complication after a cholecystectomy. The bile can leak for several days before the patient will develop symptoms, so it's really important to monitor to make sure they don't have any leakage of the bile because then they can get peritonitis. As far as assessment for patients with cholelithiasis, check the color of the stools, check the biliary drain, especially if they do have a biliary drain, to make sure that it's functioning properly. If they did have laparoscopic surgery, watch for GI symptoms, distension, fever, pain. Make sure that they are passing gas until their bowels are able to start functioning. Main goals as far as the nurse is to help control the pain, improve the respiratory status, prevent venous thrombosis. They will be on a fat restricted diet for the first 4 to 6 weeks post-op, and then they can slowly reintroduce fat into their diet, but they need to be cautious with doing so, especially if they had their gallbladder removed. Make sure that they're ambulating. They can splint to reduce pain for turning, coughing, and deep breathing. Initially, they will be NPO with an NG tube, and then they will slowly resume diet, starting with clear liquid, full liquid, bland, so on and so forth. Pancreatitis. There are two basic categories of pancreatitis. It can be acute. It can also be chronic. Acute pancreatitis is often a medical emergency. The pancreas's own enzymes are triggered while still within the pancreas, causing vasodilation, increased vascular permeability, necrosis, erosion, and hemorrhage within the pancreas itself. Pancreatitis can also be caused by bacterial or viral infection, but that's very, very rare. Diagnosis is done through getting an H&P. They'll do serum amylase and lipase levels, and they'll be elevated. And then an ultrasound, CT, and MRI can also be done to look at the pancreas itself. Treatment, the patient will be NPO. They can get enteral feedings. If those are not tolerated, they'll get parenteral feedings, and they'll get pain management. And they will generally be NPO until the pain has subsided, and then they'll have food slowly reintroduced. The patient is monitored generally in the ICU, especially with acute pancreatitis. Biliary drains can be placed to reestablish drainage of the pancreatic enzymes, and so then you want to monitor those drains. ABGs are used to monitor respiratory status as well as acidosis, because that's a potential. Hemodynamic monitoring will be done as well. The patient will be put on an insulin drip to control their glucose because they're generally not producing enough insulin. They can be given IV fluids to treat hypovolemic shock. They might need calcium and magnesium supplementation, especially if the GI system is involved. Necrosis of the pancreas can lead to hemorrhage, septic shock, and multi-organ system dysfunction, and that needs to be monitored for as well. Cysts can occur in the pancreas from local necrosis due to acute pancreatitis. Diagnosis is done through an ultrasound, CAT scan, or ERCP, so they can visualize the cyst. The treatment is drainage of the cyst through a suction tube. As far as nursing is concerned, you want to maintain the drainage device, protect the skin, as well as because the contents can be erosive if they start to drain around the skin. Pancreatic cancer is the 4th leading cause of cancer death in men in the United States and the 5th leading cause of death in women in the United States. Patients will complain of pain. You'll notice jaundice. They will have weight loss, but this is later on in the disease process. Cell samples are obtained from the pancreas through an ERCP or a PTC, and those are then sent off to the lab for diagnostics. Surgical treatment is often difficult. Completely removing the pancreas is rarely possible because of the location of the tumor and the late diagnosis. Radiation is generally not very successful, but it can be more successful if it's coupled with chemotherapy. People who have pancreatic cancer generally are put on palliative care because they don't have any signs or symptoms, and it's not caught until it's too advanced for them to have any kind of treatment to the point where they can go into remission. A Whipple procedure is one of those last resort type things. It is a very risky procedure, a very long procedure, and the patient, it has a high mortality rate, and even afterwards, the patients can have a lot of complications. But during the surgery, the gallbladder, a portion of the stomach, the duodenum, and the proximal jejunum, as well as the head of the pancreas and the distal common bile duct are all removed. The surgeon will then reconstruct and connect the remaining organs. Again, it is a very, very difficult surgery. It can be the last resort for someone with pancreatic cancer if they are a candidate. They will be in the ICU after the surgery. They'll be put on hemodynamic monitoring. They'll have arterial and venous lines, and they will be on a vent as well. Afterwards, the patient will have long-term malabsorption syndrome, and they will also have diabetes and need to be treated for that. Education is a priority and focuses on how to control pain, parenteral nutrition, which will be required initially, wound care, skin care, drainage management. Patient will most likely go to a skilled nursing facility or long-term acute care after they are done with the hospital for further recovery and rehabilitation. It is a very, very, very difficult surgery for the surgeon and then for the patient to heal from as well. And this is just an example. After pancreatic surgery, your patient's going to have an NG tube. Obviously, they're going to have the incision because they had surgery. They're going to have a sump drain 2 suction. They'll have a J tube, and they'll have drainage tubes on both sides. And the T tube can be used to help with irrigation, and then it will go into drainage to suction. So there's a lot going on there. There are a lot of chances for fluid volume deficit, hypotension, tachycardia, shock. So they'll be in the ICU for quite a while.